You're on mute, Dr. Lucaси.
Sorry.
Okay.
Are we on?
Yes.
We can hear you good now.
Great. Great. Wonderful. Good morning, everybody. Thank you so much for joining our February Mountain West AETC AIDS Clinical Conference. We are very excited today to welcome Dr. David Spach, who is the clinical director of the Mountain West AETC and a professor of medicine at University of Washington, who will be talking to us today on an update on vaccines for people with HIV. As a reminder, just before I turn it over, please remember to put in questions, comments as we go along in the Q&A box, and we can pose those to Dr. Spach during the talk, breaks, and at the end. So Dr. Spach, thank you so much for joining us. Really excited to hear what you have to share with us this morning.
Great. Julie, thank you so much. I think this is really a fun topic and an important topic to talk about because it seems like through much of my experience with HIV, it was trying to keep up with all the antiretroviral recommendations, and those have really slowed down. But I think if you look around, the vaccine recommendations are really hard to keep up with. So I think this is an important topic, and my goal with this is to really make this very clinically focused, practical, the nuts and bolts of really how to give vaccines to people with HIV. I just want to say one thing. I don't like using any brand names really at any time. But with vaccines, it's impossible because vaccines are not assigned traditional generic names. So throughout this talk, I will be using trade names in multiple times. And this is really just to keep things straight so we are all on the same page. But I apologize in advance. So there's just not an easy way to do this when discussing vaccines because of the lack of these generic designations for vaccines. Okay, here are the vaccines that I'm going to discuss. Pneumococcal vaccines are super important with HIV. I'm going to focus a lot on that at the beginning. I'm going to talk about meningococcal vaccines, even going to dive into could meningococcal vaccines have a potential benefit for preventing some cases of Neisseria gonorrhea or gonococcal infections. I'm talking about hepatitis B vaccines, where I think there's the most complexity in decision making that we make, like with things with isolated core antibody and what do we do in that setting. Talk about zoster vaccine, which I think has become a go-to standard recommendation for all adults with HIV. Mpox vaccines, including post-exposure prophylaxis with Mpox vaccines, and then very briefly RSV vaccines and what are the actual recommendations for people with HIV, which I think many people aren't that familiar with. And I'm just going to mention at the end a few things about live vaccines, which we should all be avoiding in people with HIV, especially in situations where people's CD4 count are less than 200. So there, and I should clarify that there are live vaccines that are contraindicated in certain situations, and that's what I'm going to discuss. Okay, let me jump in and start on pneumococcal vaccines, which I think we all are frequently administering in this clinic. We've used over and over again. This used to be really, really complicated, and now it's gotten much simpler, which is great. So the first question is, what are the recommended options for pneumococcal vaccine and pneumococcal vaccine naive adults with HIV? So, for example, a person new to the clinic who's never received care for HIV, has not received pneumococcal vaccines. What do we now say are the options? And there are now 3 options recommended in the adult opportunistic infection guidelines. And throughout this talk, I'm really going to focus on not my opinion. A couple places I will designate where I have a strong opinion about something, but I'm really going to try to focus this based on what our national opportunistic infection guidelines on that. And I'll mention that at the very end. So pneumococcal vaccines, there's 3 options. There's the pneumococcal conjugate vaccine 20 serotype vaccine, PCV20, which you give 1 shot and you are done. There's PCV 21 serotypes, again, 1 and done. PCV 15, there are 15 serotypes, but 8 weeks later, you have to then give a second dose of the PPSV 23. And I think a lot of people call this 1 and 1. And the latter, the last, has not been used nearly as much because it requires this 2-dose series. And again, the simplicity of 1 and done has really taken over, I think, what we do with pneumococcal vaccines. Now, this is a little more complicated than it first looks, because the question is, PCV 21, at first glance, 21 sounds better than 20. So what is the clinically relevant serotype that is absent in PCV 21? Now, this is really interesting. If you look at the serotypes in PCV15, the dark blue, and then you look what's added in with PCV20, the light blue, you can see PCV20 is just PCV15 and more. So there's no downside of PCV20 in terms of the serotypes. But look at PCV21 and compare this to PCV20. Just look at those last two rows. There is not a big matchup all throughout this. The point of this slide is that PCV21 and PCV20 are not the same vaccine at all. There are markedly different serotypes in these, so they should not be viewed as equivalent. And the real question is, what's the big difference in these two bars that makes clinical relevance? It's serotype 4. And this is not just an esoteric thing. This is a huge issue that the CDC put out an MMWR about. They track these data that I'm going to show you a little bit about. And I think this should be what determines, or at least should factor in, what we're doing with pneumococcal vaccines. So what do we know about this serotype 4? Serotype 4 in certain regions of the country is responsible for at least 30% of invasive pneumococcal disease. And that's really the thing that we're trying to prevent the most, is invasive pneumococcal disease. This geographic risk has been shown in these areas, especially in the Four Corners region and our region. It's been studied in Alaska and Oregon. Those are the states that have been tracked. We know that the rates are very high in the Western United States. So looking at this in terms of practical recommendations, then, the OI guidelines, I think, put out a very clear recommendation that you should not use PCV21 if the prevalence of pneumococcal serotype 4 is greater than 30% in the region where you are administering this. So I think this is a really important thing that people understand, and I think what we're going to see is a lot of geographic differentiation of who's using PCV21 and who's using PCV20. And discussions with some other clinicians across the country, a lot of people on the East Coast are using PCV21. People on the West Coast are using PCV20. These data from the CDC that get tracked regularly would back that up. So if you look at this, green is good in terms of low incidence of invasive pneumococcal serotype 4. If you've got a red box, that is prevalence greater than 30% of the invasive strains in your area are serotype 4. So they don't track these data in Washington State, but you look at what we're bordered by, Alaska and Oregon, and you look at age group to the left, 19 to 49. You look at that blue bar across, Alaska and Oregon does not look good in terms of invasive serotype 4. Very high rates. Same thing in people 50 to 64, very high rates. So my takeaway from all of this is that in our region, we really should be using PCV20 because it includes serotype 4. And again, for those of you that are interested in following this, the CDC has this very nice site that I included the URL at the bottom that tracks all these data year by year. So now the question comes up, okay, some practical issues. What do you do if your patient comes in and they've already received an older pneumococcal vaccine? Remember, we used to use PCV13. That was the gold standard. Some of these individuals got PCV13 and one or more doses of PPSV23. So this is now very simple. And I should say, just to clarify, PCV means conjugate. The PPSV is a polysaccharide vaccine, which doesn't give you as longer lasting and as good of T-cell immunity, and that's why we've really moved to the PCVs as our main pneumococcal vaccine. They give better T-cell immunity and longer lasting immunity. Okay, so what if they've already gotten something before? Pretty simple. If they have just gotten PCV13, which was commonly administered, 4, 5, 6 years ago, you just can basically finish this off by just giving one dose of PCV20 or 121. And again, this is going to be more than a year ago because we haven't been using PCV13 for at least a year. So let's say a person comes to the clinic, they're new to the clinic, they haven't been engaged in care for several years, and you notice they've not gotten updated pneumococcal vaccines. You could just give them PCV20 and they would not have to worry about it again. Now, what about a little bit more complex? If they've gotten PCV 13 and a dose of PPSV23. The take-home point, again, you can just finish this by giving one dose of 20 or 21. Again, in our region, I would give PCV 20. Notice though, after PPSV 23, you should be waiting at least 5 years. And the question always comes up, well, why do you need to wait? Is it a danger? It's really probably not any safety issue. It's called immune interference. And there are some data to say that if you give this too early after the PPSV 23, you don't get as good of an immune response. And we really want to make sure, if we're one and done, that we're giving it at a time that we give that there's a good immune response. Now, what about in your older individuals where they finished everything? They did everything. Let's say they're 70 years old. They got all their doses. They got their age 65 PPSV 23. What do you do then? Well, if you're seeing geriatric patients in the clinic, you can still do one more dose, but that's considered optional. So this is one where it's just shared decision making. I think either route that you take, this is a very safe vaccine. So I personally, and people over the age of 70 now who've finished everything off, I would just administer a dose of PCV 20. But that's my opinion. But right now, this is considered shared decision making. Okay, Julie, if there's anything, you jump in if there's anything in the chat, but otherwise I'll keep going. Okay, let me turn now to meningococcal vaccines. And Julie, can you clarify there's nothing in the chat right now?
Nothing in the chat, David.
Okay, perfect. Okay, so now let me shift gears to meningococcal vaccine. And this has, I think, become harder to understand and harder to keep up with because we now have several different types of meningococcal vaccines. And I'm going to try to walk through these very briefly. So we now have what the key core meningococcal vaccine that we want to make sure all adults with HIV are getting, which is the conjugate quadrivalent meningococcal vaccine. And you can see the letters there, A, C, W, and Y. Those are the key serotypes that we're giving in this vaccine. And the trade names for these are Menveo and Menquadfi. For those of you who've been doing HIV care for a while, you remember we used to give Menactra, but that's no longer available in the US. But they can be replaced if they got Menactra before. Now, meningococcal B vaccines are generally only recommended for younger individuals where the epidemiology supports that. In the OI guidelines, they say we could be giving this to 16 to 23 years old with shared decision making. And again, this is really a vaccine to focus on for younger adults, older teenager, young adults. Now, what's newer and a little bit more complicated is a combination of the quadrivalent and the meningococcal B and what we call meningococcal pentavalent vaccines, which have 5 serotypes in them. They have the 4 in the quadrivalent and they have the meningococcal B. And those are called Pembrea and Penmenvy. In the world of HIV, you would really only use those if you're having a 16 to 23-year-old that you're initiating and you're thinking about, I'm going to give them both the quadrivalent and the B. That would be the place to give this. Now, let me turn back to B for just a second and notice that they are different. So meningococcal B4C is called Bexsero. Meningococcal B FHBP is called Trumemba. And I just want to emphasize that because when we talk about the meningococcal and we talk about gonorrhea prevention, this is very relevant, which one of the two we're talking about. Okay, now, just sort of conceptually, when you do the quadrivalent meningococcal vaccine, these are the outer polysaccharide capsule of these serotypes of the meningococcus that we're using in the vaccine. And they're attached to a conjugate protein, same idea with the conjugate pneumococcal vaccine, that just gives a better immune response. Notice that B, you don't use the actual, the outer polysaccharide capsid because it doesn't give good immunogenicity and it maybe causes some cross-reactivity with neural tissue that has led us not to use that in sort of as a standard outer polysaccharide capsule vaccine. So this is an example of Menveo. This is Menquadfi. And notice the only difference here is that the actual toxoid protein that's used with this is different. So the conjugate is different, but otherwise they're the same serotypes. So essentially you should view them as very, very similar vaccines. Okay, now, what do we recommend for people with HIV? It's very clear that the guidelines say everybody with HIV, essentially a recommendation, should get the primary vaccination series with the quadrivalent meningococcal vaccine, all adults. If they were vaccinated as a child, you would only need to give them a booster dose, or as a young adult or a teenager, you'd only need to give them a booster dose. So then for our patients with HIV, there's not as strong a recommendation, but basically it is recommended to continue to give boosters every 5 years. I would say that's been consistent in recommendations for years. I would say that if, most places looked at sort of quality control, this is probably one of the things we don't do as robustly as some others. And I get it. There's so many vaccines to give. There's a lot to give, but this is in the guidelines. You should know it is recommended to give a booster dose every 5 years. Now, one question comes up. If somebody comes in new to the clinic, should we wait to give the meningococcal vaccine series? And there isn't a strong recommendation to wait in this setting, but I do want to show you these data, which are the best data that came out. And this was in adolescents and young adults. And this is looking at individuals with CD4 count, CD4 percentage, I should say, less than 15, or CD4 percentage 15 and greater, which is roughly around a CD4 absolute count 200, under and over 200. And you can see that the immunogenicity generated with the quadrivalent meningococcal vaccine was clearly a lot better with the higher CD4 percentage. So I think unless there's an immediate need to give, this is a vaccine that, based on sort of the priority list and just thinking about all the logical things to do, I wouldn't try to give this one in the first couple visits. If they have a low CD4 count, I'd at least get their viral load suppressed, try to bump up the CD4 count some before giving it. Now, one of the questions that tends to come up a lot, generated by some patient request, is would you expect the meningococcal vaccine to have some protection against Neisseria gonorrhea? And this is not a yes or no answer. The answer is it depends, and it's a little bit. So let me run through this very briefly. So as I mentioned, the meningococcal B vaccines, there were two different ones. The one that is called Bexsero, MenB4C, actually has 4 recombinant antigens as the components of this vaccine. This FHBP protein, this Neisseria adhesion A protein, and this NHBA, and this outer membrane vesicle protein. The bottom line is these latter two have very high cross specificity and reactivity with the proteins that are on the outer surface of Neisseria gonorrhea. So in studies, multiple that have looked at this, interestingly, this MenB4C is estimated to have some protection against gonorrhea. Now, would I advise somebody you take this and you don't have to worry about getting gonorrhea? Absolutely not. But if you had, let's say, a teenage individual or an older adolescent who was a candidate for meningococcal B vaccine and they had, let's say gonorrhea in the past, this is at least something to consider where you may ameliorate the risk. You're not going to eliminate it, but you may be able to help some. So I'm not necessarily advocating this should be a strategy, but I am saying if you are going to use it for a strategy, you should know which one to use, which is the Bexsero, which is the MenB4C. They're not all the same. So here's the bottom line on which vaccines would have some protection, not a lot, but some protection against gonorrhea. It's the MenB4C for the meningococcal B vaccine. And notice that in the pentavalent vaccine, which is the combination of the B and the quadrivalent, it's the PenMenV, the last one. And you can see the red line there, the meningococcal B4C, that is what's in the pentavalent. So, when would you use the pentavalent? You'd probably only use it if you had, let's say again, an older adolescent that you were going to be giving both of these vaccines, and you could make an argument that, hey, for simplicity, give them 2 doses 6 months apart, and you've got both things covered. And then from there on, if you need booster doses, you would isolate it out to the conjugate vaccine, the quadrivalent conjugate vaccine for booster. Okay, so that's meningococcal B and the quadrivalent vaccine and the new pentavalent vaccine. Now, let me shift gears to hepatitis B vaccine, which I think has the most complexity in clinical practice for what we do. So first of all, let's understand kind of the two camps of the hepatitis B vaccine we have. We have the old hepatitis B vaccines, which are traditional aluminum adjuvant vaccines. So all the hepatitis B vaccines that we use are based on using hepatitis B surface antigen. So when you give the vaccine, you're giving the individual hepatitis B surface antigen combined with something else. And in the case of the older vaccines, which are called Engerix B and Recombavax HB, the adjuvant is aluminum. This is not a new adjuvant at all. It's been around for years. It is considered probably only a moderately potent adjuvant. And the idea of an adjuvant, which is a little different than a conjugate vaccine, is that it's not actually really attached to the surface antigen. It more just activates in general the immune system. So it's a way to signal the immune system to have a heightened response to the vaccine. Whereas the conjugate, you've actually got something attached to it that immediately is visible to the immune system right away with that. Okay, now the newer vaccine called HEPLISAV-B, which I think everybody's familiar with, has a very potent adjuvant called CpG 1018. And this is a really fascinating adjuvant. It's a small oligonucleotide, and basically it turns on toll-like receptor 9. And this just, without getting into complexity, this is a way to signal certain immune cells to become activated in the setting or in the surrounding of where the hepatitis B surface antigen is being presented. So that's what makes HEPLISAV-B so special and different. It's this TLR9 agonist, this new adjuvant that really makes it unique. That's why it's different. It's the same antigen. That's not the difference. It's the adjuvant that makes it unique. So what are the current recommendations for people with HIV? And this has changed a lot. This went from sort of thinking about HEPLISAV-B to it's probably a good idea to use HEPLISAV-B to, oh, we should be using HEPLISAV-B to it is strongly preferred now for all initial Hep B vaccines in people with HIV that we should be using HEPLISAV-B. The language is strong enough that the alternatives now say only use an alternative, the older vaccines, if HEPLISAV-B is unavailable. So this is really a major change in the field of HIV vaccines. We should really be using HEPLISAV-B. And one of the major reasons is that the simplicity of it, that you give 2 doses a month apart, and it is very highly effective. Now, what is the data to say this is really the right decision to move to really using HEPLISAV-B as upfront as the go-to vaccine? So this was a very well-crafted study that looked at 2 issues. It looked at how good does hepatitis B vaccines work in people who've never had it, people with HIV who've never had hepatitis B vaccines. And then the second issue, which I'll discuss in a minute, is what about if they didn't respond to hepatitis B vaccine? Okay, so the first issue is in vaccine naive respondents, which was arm B of the study, they looked at people who clearly were hepatitis B surface antibody negative, and they looked at giving them 3 doses of HEPLISAV-B. And if you're just following a minute ago, you remember that I said it's simple. You only give 2 doses a month apart. So I'm going to explain the 3 doses in this study and how we can reckon with that. Note the entry criteria over here to the left, though. This was a pretty stable patient population with most they had to have a viral load less than 1,000, and note the median CD4 count was 625. So these were non-pregnant individuals. So I think we are dealing with a subset of people with HIV who have more, I think, intact immune systems, and I think that's one caveat about this study to keep in mind. But if you look at the actual serologic responses, this graph tells a very convincing story. We say a person has a serologic response if they get their Hep B surface antibody titer to 10 or above. Typically, that's a level around that. So yes, they got 3 doses of this, as shown in the blue diamonds at the bottom. But what I want to point out is week 24 bar. Though blood was drawn then before they got their 3rd dose of the vaccine. And notice the serologic responses were tremendous then before they ever got their 3rd dose. And because of this, I think very wisely, it was said, oh, you probably only need 2 doses in people with HIV who've never been vaccinated before. But if you give 3 doses, you get an even better response. Okay, so here's what breaking out the serologic titers look like. So if you look at, again, this same, and imagine just the blue bars there have been replaced by this more specific, the pink indicates super high titers above 1,000. And you can notice that after that third dose, 84% of people had these super high titers against hepatitis B. And whether or not that's relevant, some people are starting to think maybe for the long term that that's going to turn out to be a relevant issue to really get these titers up really high. But for now, we know that before the third dose, that even 50% of the people are in that high range of over 100. So again, very, very good serologic responses with HEPLISAV-B. So the next question is, what do you do if a person didn't respond to the old hepatitis B vaccine? So again, vaccine responder, somebody who didn't get to an antibody titer of 10 or greater, or depending on what your lab, something very similar to that. Okay, so here's what the guidelines now say. If you had an individual client that you're following, they had Injurex B or Combavax, and that vaccination series failed, you can now give them the HEPLISAV-B, definitely give them the 2 doses. You could also consider giving them a third dose. I think what some people are doing is giving 2 doses, checking a titer a couple months later, and if it looks great, stopping there. If it looks maybe a little bit above 10, not so great, maybe giving that third dose. But again, 2 doses at least, consider giving a third. Now, this is the data that backs up these recommendations. Again, back to the Beehive study, this was the other part of it where they looked at, well, how good does the HEPLISAV-B vaccine, which is Hep B CpG, that's the adjuvant, so that's what I've got listed there. How good is HEPLISAV-B, the blue and the purple, if the person didn't respond to a previous vaccine? So they looked at giving 2 doses of HEPLISAV-B, 3 doses of HEPLISAV-B, or traditional Injurex B at a standard dose. And again, these are people who had pretty high CD4 counts. So look at the responses. With 2 doses of HEPLISAV-B, greater than 90%. With 3 doses, almost 99%. And that's why we have this recommendation, I think, to give 2 or 3 doses for people who haven't responded. And so this is the overall recommendation now for people who didn't respond to HEPLISAV-B. Oh, I'm sorry. So that the recommendation then for people who didn't respond is 2 doses, consider giving a third dose. The last point about non-responders, and hopefully we won't see this a lot, but what if you give HEPLISAV-B vaccine and a person doesn't respond to that? That's what this graphic is. The guidelines say really probably the best option is to go ahead and give them a third dose. If they already had 3 doses, then basically get expert consultation because there isn't any clear recommendation at this point what to do. If somebody had started off with a really low CD4 count when you gave these initially, you could certainly make an argument to try this series, a whole series again at a higher CD4 count level. But right now, the standard recommendation is if they've had 2 doses, give them a third dose and try again. Hopefully we won't see that a lot. Now, what about this one is the hardest issue in the clinic that comes up related to Hep B. So the question is, I should say, how do you manage isolated Hep B core antibody? They're surface antigen negative, surface antibody negative, but core antibody positive. And here's the concept of what's going on here. The purple is Hep B surface antigen. And when we talk about Hep B resolved infection, the Hep B can be resolved by the natural immunity. And, most adults, or at least 50% of adults roughly, but most people, when they resolve infection, almost all continue to have a very high core antibody the rest of their life. Not from vaccine, but from the real infection. That's the red line. The yellow line is surface antibody. And many people maintain a great surface antibody titer the rest of their life if they resolve hepatitis B infection. But there are a subset of people where this drops off. And they maintain a great core antibody, but their surface antibody drops off. And this is what's called isolated core. You can certainly see this picture where their surface antigen purple would be negative if you checked it. Their surface antibody would be negative, but their core antibody would be positive. Now, some of these individuals may have low levels of replicating HBV DNA. This is in the world of, in the clinic of HIV, this is probably actually really unlikely to see because most people, they're receiving a TDF or TAF-based regimen, and most of these people are going to have suppressed HBV DNA levels, but it is possible. Nevertheless, it is not routinely recommended with isolated core to check an HBV DNA. That recommendation varies among certain experts, but in the OI guidelines, they do not recommend routinely checking HBV DNA. What they do recommend, if you get isolated core, is this. Give 1 dose of any hepatitis B vaccine, a standard dose, and then check a Hep B antibody titer in 1 to 2 months. And the key thing is your titer cutoff here now in these isolated core to focus on is 100, not 10. So if it's above 100, you are home free. They're considered immune to HBV, and there's some data to support they probably will maintain that. However, if they're less than 100, and again, normally we use a cutoff of 10, they should get a full hepatitis B vaccine series, and after that, get their antibody titer checked. So now the question is, why do we use this 100 in this setting? And the issue is this: 100% in this one study where they looked at this, 100% of people with isolated core who achieved a titer of 100 after a booster dose maintained it for at least 18 months, with compared to only 23% of those who got to a titer of 10 to 100. So the bottom line is, if you get above 100, you probably keep it up to that level. Now, this is one place where just my opinion. This is not in any guideline anywhere, but based on the climate, based on the responses to HEPLISAV-B, based on the complexity of this, I hope we can simplify this recommendation at some point and just give people 2 doses of HEPLISAV-B and call it a day, because I think that is much more likely to clarify, lead to a lot fewer blood draws, and make this a lot simpler. But that's just my opinion on how we might handle that in the future. Okay, let me shift gears to the zoster vaccine. This is a routine recommendation now for all adults with HIV. As a reminder, we're using the new Shingrix vaccine, which is not a live vaccine. The recommendation is to give 2 doses of this at least 2 months apart. You can give it even if they've had shingles in the past. You can give it if they've had Zostavax in the past, which was the old live vaccine, and you can give it regardless of CD4 count. The one circumstance when you should not give it is if a person is right in the middle of or just resolving an acute episode of zoster. Probably should wait at least several months after that. Now, what's the data to say it's okay to give it in people who've previously been vaccinated with the Zostavax? And this is just to show you that you get great immune responses to this new Shingrix vaccine, regardless of whether or not you had Zostavax. The blue is prior zoster vaccine, the green is not. Again, great responses. So the take-home point is, if somebody had the Zostavax, it's fine to go ahead and give them, and it's recommended actually to give them the Shingrix, and I would go ahead and do that. Now, here's something really interesting about the shingles vaccine, and many of you may have started to hear about this, and I don't think this is now, National Enquirer. I think this is now moving more into the mainstream as we hear a lot of bad news about vaccines, a lot of bashing of vaccines. I think it's really, interesting to see this unexpected benefit that may be seen with the shingles vaccine. It's now also been seen with both of the vaccines, the live and now the Shingrix attenuated recombinant vaccine. So again, this appears that there may lower the risk of dementia. There may even be some lowered cardiovascular risk. So I won't go into this to detail, but keep your eyes on this as another reason to advocate for shingles vaccine in the future. So a couple quick questions. Would you give the zoster vaccine to a 30-year-old who got varicella vaccine as a child? We're going to be seeing a lot of these young adults who've only been vaccinated and they never had chickenpox as a kid. And the answer to that is yes, because the varicella vaccine is live. People probably have some risk of zoster. We don't really know a lot about this yet. Probably a good idea to give it, but stay tuned on this as we learn more as these individuals who are vaccinated age and move into an age where risk is a lot higher. Now, what about if they've a 35-year-old with HIV, nice CD4 count above 500, who's not had varicella vaccine, chickenpox, or zoster? They've not had essentially any immunity or any vaccination. What should you do in this setting? Should you give them the Shingrix vaccine? In this setting, since their CD4 count is above 500, you would just give them the varicella vaccine, give them 2 doses, 3 months apart. We don't know the efficacy of the zoster vaccine as primary varicella prevention. We don't know that. It's possible it could have some, but we don't know that. So the current recommendation would be no immunity, no previous history of it. You would just give the varicella vaccine. Okay, now let me shift to Mpox. So Mpox, the question with Mpox to start with is it contraindicated if you have a CD4 count less than 200? And the answer to that is it depends. So the Mpox vaccine that we use over and over again is called the Jynneos or the MVA, the modified vaccinia and Cara vaccine. That is totally fine to give to people regardless of CD4 count. It is a live vaccine, but it's attenuated, non-replicating. So this is very confusing, but it doesn't replicate, so it's considered very safe regardless of CD4 count. On the other hand, the true smallpox vaccine, ACAM 2000, is a live replicating vaccine. It never should be given to anybody with HIV. And that's a really clear recommendation. So I just wanted to sort that out. What is the Mpox recommendations? These should be basically 2 doses of the Jynneos or the MVA vaccine spaced at least a month apart. And this vaccine isn't perfect, but it does have good efficacy. And certainly people who get it, who it doesn't 100% prevent, they seem to have a lesser severe illness, even if they didn't get true immunity to prevent from infection. So very good efficacy, not perfect. So how do you get this vaccine? So the standard is to give it as a subcutaneous injection. But as a reminder, you can give 1/5 of the dose as an intradermal injection. This is not so important when there's a good supply of the Mpox vaccine, but when there's shortages, which could occur if there was a big outbreak, this can be done. You can use 1/5 of the dose. And as a reminder, this shouldn't be done in people younger than 18, so it's just for adults, the intradermal injection. And I wouldn't give the intradermal injection to anybody who's ever had keloid formation. It's not recommended in that setting, but it can be a very nice way where you can essentially spread the vaccine out over time because it's only 1/5 the dose. Now, a couple questions about Mpox vaccine or the Jynneos vaccine that come up. So in the United States, is this vaccine recommended for someone who was previously diagnosed with Mpox? This comes up in the clinic. People come in, they've had Mpox before, they say, hey, do I need the vaccine? And the second is, are we giving booster doses? And, maybe even what about CD4 count less than 200? Would you double consider sort of, or even more strongly consider giving a booster dose? So these have been addressed in the OI guidelines. And the answer to, do you give the Jynneos to someone who's previously had Mpox? The answer to that is no. It appears that reinfection, even among people with HIV, is very rare. And it appears that if people do get it, it's a self-limited illness if it does occur. The guidelines also address booster recommendations, and they don't recommend it in our country for people with HIV. There are breakthrough cases. These are uncommon in people who have been vaccinated, but there are breakthrough cases. It appears they're much less severe and they're with fewer lesions. So I would say that, between these 2 recommendations, there's a little bit more controversy about the second recommendation, but this is currently what's in the OI guidelines now, is no booster doses for Jynneos. Now, it could be we learn data down the road that maybe changes this recommendation, but this is where we're at now. Now, what about this? Can you use the Jynneos Mpox vaccine as post-exposure prophylaxis? So let's say someone's never been vaccinated before. They get a phone call from a partner who says, hey, I was diagnosed with Mpox. They had sex with them several days ago. What can you do for post-exposure prophylaxis? So there are clear recommendations for this in the guidelines. There's not a lot of data, but there are, I think, a good theoretical and some data to suggest this would be helpful. So here's the extrapolation is it depends on how long ago the exposure was. So if somebody comes in and they say, hey, this was 2 days ago, the top one here, where it's less than 4 days, you go ahead and you give them just like you're going to vaccinate them. 2 doses a month apart. Nothing wrong with just vaccinating them anyway. And in this setting, you probably have a very good prevention of primary infection in this setting. If it's a little bit farther out, you're now 4 to 14 days out when the exposure was, it may prevent infection, but more likely what you'll do is get actual infection, but a less severe illness. So the take-home point from this, if somebody does have an exposure, it is advised that they get in as soon as possible after this to get their 2 doses of the Mpox vaccine. But it is certainly worth making an attempt to provide some protection out to 14 days. And the same dosing for this should be used as you use for the standard just primary vaccine series. Now, let me wrap up with the RSV vaccine in terms of the different vaccines. So this is a vaccine that we don't think a lot about with HIV, and we're kind of nearing the end of the RSV season, although we just saw an individual in clinic the other day who had been hospitalized with RSV. So it's definitely there. It can definitely cause serious problems. And I just wanted to mention and go through briefly what is in the OI guidelines. So there are 3 different types of RSV vaccines. And this kind of went through people not even being aware there was an RSV vaccine to suddenly now we've got these 3. But they're not all the same. One is essentially an adjuvant fusion protein. So it's one protein of a subunit. And then the second one, that's called Arexi. The second one, Abrysvo, is a bivalent or 2 proteins that are these F proteins. And then the third is actually an mRNA vaccine. So we have these 3 different ones. They're all basically recommended for everybody 60 and older, but otherwise the recommendations are a little bit different. And the RSV pre-F is the only one that is currently recommended for use in pregnancy. And basically, these are all considered options for people with HIV in the context of how they're recommended. So the question then is, what does the OI guidelines say about this? So here's a new recommendation or newer recommendation in the last several years that we've seen is that the RSV vaccine is now routinely recommended for all adults with HIV who are 75 years, older than 75 years. And I know that sounds like, we don't, but in the clinic now, as people are living longer, this really is a subset of people that we are seeing in the clinic, and it's important to know about this RSV recommendation. These are the individuals that have the highest risk of severe complications from RSV. The second group that it's recommended in the guidelines is 60 to 74-year-olds, which is certainly a significant number of people in the clinic now, if their CD4 count's less than 200, or they have comorbid conditions like, severe, interstitial lung disease or severe asthma or something that would increase the risk of severe RSV if they've got it. And the last thing is just as a reminder, for pregnant individuals, it's recommended that at week 32 to 36, this is given if the individual who's pregnant is in the months of September through January at the time they're at weeks 32 to 36. So for example, a woman is 34 weeks gestation in December, great. Or it's recommended routinely now for them to get RSV vaccine, including women with HIV. Okay, now let me finish by just making a comment about the live vaccines. And I've tried to leave about 15 minutes for a question and answer if people have any questions. Okay, so live vaccines we need to think about with people with HIV, especially individuals who have a CD4 count less than 200. So just as a reminder, there's several vaccines, very importantly, that are contraindicated under 200. So the chickenpox vaccine, unlike the current Shingrix vaccine, as I was mentioning, is a live vaccine that should not be given to people, adults with CD4 count less than 200. Very important, the MMR and the MMRV, which also includes the varicella, the V at the end, those are contraindicated with CD4 count less than 200. That's a really big issue as we all, become very aware of a lot of measles cases in the United States right now and likely to occur in future years. And we think about immunizing with MMR. It's important to remember not to give that if CD4 count is less than 200. Yellow fever vaccine is not recommended under 200 as well. So that's a subset of people where we would not recommend if less than 200. Then there's certain live vaccines that it's recommended not to give, essentially with anybody with HIV. The live attenuated influenza vaccine called FluMist, it's a spray, it's a nasal spray. There's no reason to give it to people with HIV. We have many other alternatives that are safe. There's no reason to give this to anyone with HIV. Vaccinia smallpox vaccine, as I mentioned, that ACAM 2000, that never should mistakenly be given for Mpox vaccine to a person with HIV. It's contraindicated. It's a very live vaccine that really could cause severe consequences with smallpox-like illness. And then the live oral polio vaccine, this is, to best of my knowledge, not widely available in the US, and so not so much an issue here in our clinics in the Northwest, but it is an important issue that people know about if they're traveling. And live attenuated oral typhoid, the Vivatif vaccine is not recommended as well for people with HIV. So the very last thing I want to say is just to summarize that I think there's certain challenges we face. There are really a lot of vaccines now that we have to think about giving, and how do we prioritize them? And I don't think there's a clear hierarchy, and I think it's very individualized, but I certainly place vaccines like pneumococcal vaccine really at the top of our list, and hepatitis B vaccine, especially with all of the two-drug regimens that are being used out there nowadays. But clearly, it'd be nice to have, more formal guidance maybe in the future about strategies for exactly sort of when we time all of these multiple vaccines and how do we juggle all of this in this day and age. The second challenge is I think it's really tough now to keep up with frequent changes in the recommendations, but I'll mention something in 1 second about that. The third is we really have this difficulty, which has gotten better now with modern record keeping, of how do you keep track of all the immunizations someone's had in the past, their Tdap, their prior, pneumococcal vaccines. It can be very challenging if you don't have good online access to what records, the records of a person who's new to a clinic, who's been seen in other places where you may not be able to get those vaccine records. So that certainly can be challenging. And then the last, which we all know and we face, is vaccine hesitancy. And I've been, really observing this and noticing how interesting it is that it's almost selected vaccine hesitancy. And many of you may have experienced this, where some people come in and they'll say, absolutely, I will not get this vaccine. I'll not get that vaccine, but oh yeah, shingles vaccine, no problem. Or, oh, pneumococcal vaccine, no problem. So it's very interesting. And I think we shouldn't assume if someone says they don't want this vaccine that you stop with that, because you always should bring up other vaccines, because it's interesting how much I think specificity there is about people's choice not to take vaccines. And I think this is always a discussion we should be trying to have with our people we're seeing, and trying to emphasize the importance of vaccines. The last thing to mention is that this difficulty of keeping up has gotten much better. And a quick shout out to Shirisha, who is really led a lot of great work on the OI guidelines. And the immunization section is a relatively new addition to the OI guidelines. It is fantastic. It's gotten better and better. It is very clear. It's just gotten really, really to be the go-to place to go for vaccine recommendations. Not only is there great written recommendations, but there's now fantastic tables, a type of more written out table on the right, the one on the left, very color-coded, kind of like ACIP recommendations, but very specific for HIV. So if you're struggling to keep up with all of this, please go to the OI guidelines. Please look at these recommendations, because that is now where I think people are going for their, they really should be going to look for the updated recommendations for people with HIV. And again, it's just a great addition to the guidelines. This is our funding slide, just to notice or to have everybody, and my disclosure about this. We're funded by HRSA as part of HHS. So let me stop sharing my slides and turn it over to Julie.
Thank you so much, David. That was great. There was a ton of information in there, and we definitely have a lot of questions coming up. So thank you for leaving time for those. The first one doesn't have a name with it, but it is, would you always run a Hep B titer to check for antibodies on a person with HIV, even if you have vaccine records?
So good question. The answer to that is if they've never had a titer documented after vaccination, the answer is yes. So it's important for clinicians to know in the OI guidelines and in other sort of quality control measures by HRSA, it's recommended that after you vaccinate against A or B or both, that you should be checking a titer to document serologic response. And that's very different than what we do out in the community. So the answer to that question would depend. Somebody came from another clinic, they'd gotten 2 doses of hepatitis B, or they'd gotten 3 doses of the Injurex or Combavax, and they had a documented great titer, I would not revaccinate them. I wouldn't do anything at that point. But if they just came and did not have a documented titer, that would be where I would start. And there's one point that I probably failed to mention. It's just not so important now because we're not really using the old vaccines. But if you do use Indirex or Combavax B, it's recommended you have to use a double dose of it. So, even when you start arguing about, oh, Heplisav B is expensive and everything, well, by the time you use these double doses and you do 3 doses and you get these poor responses, I actually think Heplisav B is probably going to turn out to be cost effective in the long run.
That makes good sense. Great. Neil Barg asks, would widespread use of the meningococcus vaccine with cross-reactivity to Neisseria gonorrhea drive Neisseria gonorrhea strains to antigenic change without cross-reactivity? And do we know if emerged strains exhibit different virulence?
So, Neil, that's a super sophisticated question that I don't know the answer to. And Julie knows more about STIs than I do. And I love this question. I don't think anybody knows. The countries where they've done this the most, and there's been the most implementation and following and study, and Julie can add to this at any point, has been in Australia. And they've tracked a lot of this. I've never heard this before, that it did drive a change and antigenicity. I don't know the answer to it for sure, but it's an interesting question. I don't know, Julie, if you have any thoughts
Yeah,
about it.
I agree. I don't think we know the answer. It makes sense theoretically. There are some large clinical trials ongoing that may give us some insight to that. So,
Yeah. And
interesting
then, Julie,
point.
just your thoughts about the meninge B. Do you agree that that's sort of the range of protection that gets bantered around and that, yeah.
I totally agree. And there was something that happened a couple years ago and added some confusion to this point, where it looked like one of the doxypep studies showed some protection with that vaccine that actually didn't pan out. So I think we're still in the range of just what you said, which is probably a little bit of protection, but only makes sense to really recommend just as you did. I think in someone who you talked about adolescents and you're giving meningococcal vaccine
Yeah.
anyway. I totally
And
agree.
it could be that there's almost like a portfolio that we think about. Maybe you're using doxypep and you're giving them the meninge B vaccine, and you know, you're trying to do
Yep.
everything you can to provide protection in certain individuals where there would be, I think, clear higher risk for acquiring, gonococcal disease.
And to be clear, I think we're not there yet. I agree. We
Yeah,
may get
yeah,
there with
totally.
some clinical trial results. All right, Elaine Thomas has three great questions for you.
Oh,
The
good.
first, is the rationale to give Hep B vaccine to isolated core positives to prevent reinfection or reactivation?
Okay, let me take that one first. Elaine, this is such a great question, and I was giving a talk that Paul Sachs was on, who's he's incredibly bright ID physician from Harvard, and he actually sort of challenges this. And I think I presented what's in the guidelines, but I would say there is a contrarian review of this that says these individuals probably aren't at risk either of reinfection or relapse. And when I've looked for the data, it's very hard to see a high risk of either, but there may be some, and it appears there's a risk to some degree for both. And so the rationale is actually for both to prevent relapse. And the setting would be, for example, somebody's on TDF-FTC plus, bictegravir or dolutegravir or whatever, or their TAF-FTC bictegravir, and you're switching them to, say, cabropivirine, a regimen that doesn't have any Hep B protection, and you find out they're isolated core. So the data that's looked at this has said, it's a really low risk, but it's not a zero risk of switching them off. So I think the answer to that is that it appears the risk is low. There's some risk of reactivation and of reacquiring, but other people have argued there just isn't the data there to say there's a significant risk at all for either of those, especially for acquiring new or reacquiring a new strain of infection at a later point. So I love this question. I would say that there are definitely people out there that have argued back and forth about this a lot. And I'm not
Great.
the world's expert on this, and I'm summarizing what's in the guidelines. So I think a lot of very thoughtful people have looked at this, and a lot of hepatologists have looked at this, a lot of ID people. So it's very controversial.
And for the next one, David, I wonder if I can invite you to distinguish what the guidelines say versus what you think or what you do as a
Yeah.
clinician, if there's a difference. So, for those with past good Hep B surface antibody response to vaccine that is now waned, say we end up checking it,
Yeah.
should we boost? And do we need to be checking surface antibody on some regular basis to reboost?
So great question. If you look at the general population, you can see, especially people that are vaccinated as children. And for all of you that are in medical care, you'll see this over and over again for the health professionals now going into healthcare. So these are the generation who got hepatitis B vaccine as a child. They're now going on to, nursing school, they're in medical school, and they're needing to get their Hep B titer checked. Not most, a significant proportion of them, when they get checked, they do not have protective antibody. And for those individuals, they make them show that they have responded to a booster dose of vaccine or they revaccinate them. So the issue is this a parallel situation with HIV? So I would say this, there's three groups of people. For people who are healthy individual who got hepatitis B as a vaccine as a child, you probably never need to check their titer. They probably have what's called adequate and amnestic response, and they would respond to hepatitis B. I think that's pretty clear from a lot of data out there. For people who are going into high risk situations, healthcare professionals who may get exposures and bloodborne exposures to high titers, the recommendation from most experts is to add that layer of protection in to make sure they boost and they get a serologic protection with a Hep B surface antibody greater than 10. So that's the current standard of care in the healthcare field where people are considered at significant risk in their health profession. I would say the HIV situation is more analogous to the healthcare situation, where the stakes are higher, the exposures are higher. And so the current recommendations are that, yes, you would probably boost that individual. That's what I would do, only because I think the vaccines are very safe and there's very low risk of that. But I would say we will probably learn more about this over time. Again, this is one of the areas where how good is amnestic response? How good is your memory response may depend on what your baseline immunity and what your risk and your inoculum is when you're exposed. And these questions I don't think are definitively answered. So my own opinion is I would boost that person, but I would also say you could make an argument. Most people, especially if they have a high CD4 count, probably would have a good amnestic response.
Great, thank you. And David, we've got at least two more questions. We're going to switch to MMR from Elaine, and then Jihan has a great one about Shingrix. So Elaine asks, for patients who have one remote MMR documented, should we give a second MMR as long as their CD4 is above 200 or check the antibody?
So just as a reminder for everybody, you kind of get out of the need to get an MMR vaccine for a couple of things. So if you were born before 1957, so this essentially now is going to be in our current year, people that are 70 and older, because 2026, they don't need measles vaccine titers check. They don't need measles vaccine. So if someone had documented two vaccines, which is not what Elaine's saying, but they had two vaccines, they're considered protected. You don't even need to check a titer on them, with the caveat that people who were received the vaccines in the years 1963 to 1967, I think there are a lot of experts that would check a titer in those people and not view whatever they got as adequate and would at least give them one more dose. People who only got one vaccine would not be considered adequately protected. If they are a younger individual and they're very unlikely that they ever had live measles exposure, I would check a titer in them, I would go ahead and give them their second dose, and then I would check a titer. Because I think it's just for the rest of their life, just get it finished off. But again, I would not give them MMR if their vaccine, if their CD4 count was less than 200, because that's clearly contraindicated if they're less than 200. If they're 250, I'd probably check a titer and be a little more cautious about it. But if somebody has a really nice, robust CD4 count, suppressive antiviral therapy, I'd feel comfortable following the recommendations. They only got one dose, give them another dose of vaccine.
Great. So from Jihan, thank you, David. In your shingles versus varicella vaccine scenarios, in case number 2, you suggested giving varicella vaccine in someone with no immunity to it if someone had a high enough CD4 count. So if you had a patient with a CD4 under 200, would you give Shingrix or would you wait till it was above 200? And what if it never gets above 200? Would you just go ahead and give it?
Yes, I love this question. And I don't know the answer. It would be sort of, the clinician's choice. I would think this is actually, I'm fascinated by this question actually, because I actually wonder why we haven't studied using a non-live primary vaccine in immune compromised, bone marrow other people. Like, I think this is a sentinel question that, given the extremely high immune responses because of that excellent adjuvant that's used in the Shingrix vaccine, it's a great adjuvant. That could we not do that as a primary vaccine in somebody studying? There maybe are reasons why you don't do that that I don't know. But I've never heard anyone explain why that couldn't be studied at least. So considering that that vaccine is not live, I don't see any danger to it. So to Jihan's question, if somebody was less than 200 and they had no immunity at all, I would have that discussion with them. I think that's actually a really great question, and I would do it because I think and then I would, interestingly, check a varicella titer after and sort of see what kind of immune response they got. The only reason I think I would do it is because I just don't see a downside from it in that setting. And but it is a great question, and I would love to see us look at a study in immune compromised individuals using that as a primary because it's needed because you can't give to people who are pregnant, you would never give the live varicella vaccine. People who are immune compromised, transplant patients, people with HIV with low CD4 count. So great. All these were great questions, and I really appreciate the questions.
David, thank you so much for a really excellent talk. I think people are going to be interested in your slides and looking back. And thank you again for, as always, clearly educating us about the guidelines and giving us your really expert clinician guidance. You're getting lots and lots of hearts. Hopefully you can
Oh,
see
that's
those.
nice. Thank you. Thank you all. Thanks for the opportunity to
So
do this. It was great.
thank you so much. Have a great day, everyone, and thank you for coming.